And when we have these defenses, it's really hard to get to the memories because the defenses are so strong. And what I find that working with the medicine, you can really bypass these defenses and get to these memories with like, these raw memories. And this is just one type of memory. This is more, I'm talking about explicit memories, but we can also get in deeper, even into pre-verbal memories, so implicit memories. And this is really where, for a lot of our clients, that's the work.
I'm Laura Reagan and Rotem Brayer. Welcome to the Art and Science of EMDR.
Thank you, Laura. Thanks for taking the time to do that.
I always love talking to you, but I'm really interested in talking to you about your work using psychedelics with EMDR. And to start off with, what psychedelics are you working with when you do psychedelic assisted EMDR?
So glad you asked this question. Currently, the only medicine I use is ketamine, and ketamine is not a classic psychedelic. We have, I think, in the course, I'm talking about three medicine, about ketamine, about MDMA, and about psilocybin, because MDMA and psilocybin are likely to be approved by the American FDA in the near future. In Australia, they're already being used in psychotherapy. So in session, people can use them, therapists can use them as of last July, so July of 2023, can use them in therapy. And we hope that they will get approved by the American FDA. So I am certified in ketamine assisted psychotherapy, but I also recently got certified in psilocybin because I like to be a little ahead of my game, and I'm really interested in that. So I'm not doing this work quite yet, but I'm getting ready for it. Currently, I'm working with ketamine. I mean, got a lot of attention in the last few years, and I think that ketamine historically has some bad reputation from Special K and drug abuse and all that. But what I find, and research backs up my anecdotal finding, is that it's an excellent medicine for mental health. Specifically, the research is focusing on treatment resistant depression, but it's really a great medicine for mental health in general, especially when you combine it with really powerful therapeutic modalities like EMDR and IFS as well.
So, how did you get certified? What type of certification do you have?
That's a good question. So there's a little wild west of certifications and trainings and all kinds of trainings with very different standards. I got certified with a Skylight Psychedelics, and the owner lives here in Colorado. It's a doctor that I work with, I refer clients to. I know this person personally. I think they have a good program. I haven't done the other programs. I can't talk about the other programs in terms of certification. What I do know, though, is that it is really a wild west now when it comes to ketamine, like different protocols. Some people do some crazy things. And I know that because I do consultations for people from around the country. So I hear some things I would not recommend or agree to work like that. But I know it's happening. So just different programs and different ways of working. And I think that regardless of where you get trained, you need to use your clinical judgment.
Yeah, well, I'm wondering what kinds of things are people doing that you wouldn't recommend people to do? Can you share anything about
Yeah,
that?
yeah, yeah. Good question. So, some people do, for example, a high dose ketamine online group, like a group therapy on Zoom with high dose of ketamine, which again, I don't want to judge, and I don't want, before COVID, I wouldn't think that I would do so much, virtual therapy or online therapy. And now I do. And I haven't done, any of my ketamine session virtually. And I know that some people do that. I'm not judging it. But to do high dose in a group, there's something that feels wrong about it. There are prescribers who prescribe very, very high doses for clients who have no experience with any kind of mind altering medicines. And I think that's not a good way to start. And especially when the therapist doesn't have a lot of experience too. So I think that we need to learn from the history. And when I say history, I think I'm thinking about two histories of psychedelics. One is the very far thousands of years indigenous cultures. They know how to work with these medicines. They've known it for millennia, and we need to learn about that. But we also need to learn about what happened in the 60s, because in the 50s and 60s, there was a lot of use of psychedelics in therapeutic settings, a lot of good research, good outcomes, but people got too excited about it. And I think there was a backlash. So, the result was, part of it was that, the government decided that psilocybin, LSD, MDMA, all these medicines, which I call them medicines, not drugs, are now Schedule 1 drugs. So they're in the same category as methamphetamine and heroin and these really hard, dark, damaging drugs.
Yes, they scheduled them in the level where, they're considered very dangerous.
Yeah.
Yeah. And I know there were a lot of political reasons for that. So you talked about high dose ketamine in groups not being, especially online, not seeming like a real safe option. That's what I'm kind of interpreting, that you're saying it didn't seem safe.
Yeah, good interpretation, Laura.
So how do you use it with people? Is it a lozenge? Is it an
It's a lozenge.
injection?
So they take it sublingually. So I refer them to a doctor. They get a prescription. They bring it to my office. We have a checklist of things that we need to do. We need to measure their blood pressure to see that they're in a normal range. And sometimes it's a little high because they're, a little anxious. So, I tell my clients to come a little early and to do some breathing exercises and to kind of calm their nervous system down. And then we start with a low dose, which is not a psychedelic dose, it's a psycholytic dose. So the psycholytic dose is a dose that really has mind altering features, but they don't experience the full blown psychedelic dose when people, lose orientation to where they are and sometimes even who they are. This is what happens with a psychedelic dose. And when you take ketamine, in a higher dose, you really experience that. You really experience a real psychedelic experience. But I like to start with a lower dose, especially for these clients who are anxious about it. So a lot of people, and in my experience, there are two groups of people who are anxious about doing this work. One is people who had bad experiences with psychedelics, and that happens a lot when people don't
Me.
you. Okay, maybe you and I will talk about it. But yeah, a lot of people, because people don't pay attention to what's called set and setting, which I think we should talk about what set and setting is and why we need to pay so much attention. And I mentioned it maybe 20 times in the course in different setting, in different contexts. And the other group of people who get anxious about it is people who never tried it. So they, we all had, we heard some commercials. This is your brain on drugs, and drugs fry your brain. And don't get me wrong, drugs can be really bad. We all worked with clients who had substance use issues, and people can get bad effects from ketamine if they use it recreationally and irresponsibly. But in a therapeutic setting, people don't get addicted to ketamine. They don't get crazy. They don't become psychotic. It's a very safe medicine. So ketamine is a dissociative drug. By FDA definition, it's prescribed for anesthesia. And then off-label, it's prescribed for either pain or mental health. And there's research coming from these three disciplines. And so there's so much research. There's thousands of studies about ketamine, and it's a very safe medicine.
Okay. So first you start with the psycholytic dose, and then do you later do it something different?
Increase the dose. That's a ongoing conversation with the client and with this prescriber. So we're working as a team. I don't have, there are a lot of ketamine clinics now around the infusion clinics around the country, and they have very specific protocols. You use this milligram on first meeting, and then the second infusion, you go higher and higher and higher. I check in with my clients. I don't have a very specific protocol that I work with. My guideline is what is going on for my client, what would benefit my client. So if they want to go higher dose, then I talk with the prescriber. And if it makes sense, then we go higher dose. And sometimes we go into a psychedelic dose, which has its own benefits. And sometimes we just continue with psycholytic. And again, that's a case by case, that's an individual preference. And I can tell you that even these clients who work only with psycholytic doses, they benefit a lot from it. There's a lot of stuff that comes from the unconscious, the bypassing of cognitive defenses that can happen as a result of working with a psycholytic dose.
Okay, that's really great to know. And can you talk about how aware a client is during a session, and can they follow a light bar?
Yeah. So I divide the session into 3 segments, and I call it segments just not to confuse with the 8 phases of EMDR. So segment 1 is the journey, and it's basically we're doing phase 1 and 2. It's like a classic psychedelic-assisted psychotherapy. They have eye shades on, they listen to music, they lay down. I have this inflatable bed that is very comfortable in my office, and they're, to use a non-clinical term, they're tripping. They're doing the journey. And that's the advantage. This is why I like to work with ketamine. Ketamine has short half-life, as opposed to, for example, psilocybin that has, that the journey can take 8 hours, even 10 hours. With ketamine, about an hour and a half after we started, they feel like they're back in the room. And we have to educate them on that. We have to tell them, when you're back in the room, that's when we're, slowly transitioning into processing. And then we're doing phases 3, 4, 5, 6. So if we get to 5 and 6, but at least start with 3 and 4, this is when we're doing reprocessing. When the brain is in the state of neuroplasticity, we're doing the reprocessing, and then we have to do integration. And integration, and this is the 3rd segment, and this is, really taking time to have the client back into reality, like orient them into ordinary reality, because when they leave the office, if we don't leave enough time, it's not going to be good. And I know that from my own personal experience. My own therapist doesn't do medicine work, so I went and did this work with a therapist I didn't know in Denver, and he didn't leave enough time to kind of close the session. And he also had someone after me, which I think is a big mistake. For me, it's always, and again, it was a painful mistake for him. I think he realized that too, but it was a learning experience for me. So for me, if I'm doing this work, it's the last session of the day. I'm not going to schedule more clients after. I don't want to be rushed, because sometimes clients need to stay another hour or even longer, and I want to be available for that. Different people metabolize ketamine differently. So, I say about an hour and a half, but for another person, it can be 2 hours. So I want to be available for them. Now I want to address the question with the light bar. So no, we don't use the light bar. We use either music, bilateral music, and I have these speakers that you can play bilaterally. And if you go on Spotify or Amazon Music or wherever you get your music, you can get bilateral music playlists. And I also have these wearable tappers that I have my clients where at the beginning of the session, so I don't want to deal with anything when they're, under the influence of the medicine. So we do it before. And that's in my checklist. So the session looks and feels very different than any other session. So I created these checklists that I work with because otherwise I'm going to miss something. So before we start, before they even take the medicine, they put these wearable tappers on, and then we can use either tactile or music.
Okay, so just to clarify something, the length of the session, how long is it?
Good question. So usually when we work with a low dose, it's about 3 hours. And
Okay.
then with a higher dose, it's usually 4 hours. So 3 to 4 hours. Again, what I like about it is that it is more affordable than, let's say, psilocybin sessions that, I live in Colorado and I know that some people do that here. And the people who do psilocybin work usually are not therapists. They call themselves guides, and some are guides and some are just, dudes who put a website on and call themselves guides. And it's a little, again, Wild West with that. But what I like about ketamine is that you can do this work in 3 to 4 hours. So it doesn't have to take us involved in that, like both for paying for the session and having to miss work and all that. So
Yeah, okay. That's great to know. So the reason you're saying that psilocybin session would be more expensive is because the effects last longer, so the session has to be longer.
right.
Yeah. Okay.
Yep.
So what sort of issues or diagnoses might you treat with psychedelics? And then to add to that, someone said a client once told me that her psychiatrist told her that bipolar disorder is not best for ketamine treatment and can induce the opposite reaction she is seeking. Are there some diagnoses that are not the right fit for ketamine versus better suited for psilocybin, for example?
Agreed. So I'll start with the bipolar and then I'll go to generally about diagnoses. So bipolar is a little tricky. So for me, and this is what I teach in my course too, I'm not currently working with people who have bipolar disorder or not doing medicine work with people who have bipolar. That's one of my contraindications. Now, there's some studies that show that ketamine has been effective, but I looked a lot of the research and the studies, and it's not enough for me. I would wait for more research to come to show the effectiveness. I'm a little concerned about making people worse. So, what kind of diagnosis I work with? Mostly depression, anxiety, and trauma. So, mostly what I work with when I do EMDR, and I usually work with established clients. So, clients who we tried EMDR in parts work, tried EMDR with somatic work. EMDR is my thing, and then I integrate with other modalities. And if I feel like something's not moving, we're stuck somewhere, there's a block, then I would introduce the idea of adding medicine. And for me, it's not so much about diagnosis, it's more about working with defenses. So, in EMDR, we're conceptualizing the client's issues as dysfunctionally stored memories, right? That's what we learned from Francine Shapiro, that mental health issues are a result of dysfunctionally stored memories. But then when you look at complex PTSD, when you look at people who have attachment issues, people who have some repeated childhood abuse and neglect, it's not just the dysfunctionally stored memories, it's the dysfunctionally stored elements. It's these, and that's what Jim Knipe is talking about. It's these defense mechanisms that become part of the personality structure. And when we have these defenses, it's really hard to get to the memories because the defenses are so strong. And what I find that working with the medicine, you can really bypass these defenses and get to these memories with like these raw memories. And this is just one type of memory. This is more, I'm talking about explicit memories. But we can also get in deeper, even into pre-verbal memories, so implicit memories. And this is really where, for a lot of our clients, that's the work, to do this implicit memory, to work with these pre-verbal memories. And I've had this in session that, and of course, when you get to pre-verbal memories, you don't know if it's true or not. You don't know if it happened or not, but you're working with whatever's coming up for the client. And the instructions for psychedelic-assisted psychotherapy and EMDR are very similar. You're just noticing, you're not trying to get away from, like we do in a lot of other types of therapy or in life in general, right? When people have trauma, they try to just run away from any reminder of the trauma. We're going toward, and we're kind of changing the relationship with the trauma or with the dysfunctionally stored memories or whatever you want to call it. We're just becoming the observer of it. We're looking at it from, and we develop more objectivity.
Okay, so I'll ask you one more thing before we move to opening up the Q&A, because you said you wanted to go back to set and setting, and I think that's really important for people to hear about.
Yes.
So tell us what you mean when you're talking about set and setting, and why is it important in the psychedelic work?
Okay, I'll give you the general definition, and then I'll tell you what I mean, because I think that I broaden the definition of set and setting a little. So the set is the mindset of, traditionally thought as the mindset of the client. What do you bring to the session? What is your expectation? Are you expecting to heal from trauma? Are you expecting to just reduce symptoms? Are you expecting to see God? Do you believe in God? Do you believe in the spirit of the plan? Do you believe your belief system will affect the journey and the whole treatment? And when I think about the set, is also the therapist. What do you bring? What do you hope to bring for your client? What are your expectations? I think it's really important. There's a lot of things that happen during these sessions that are really hard to explain. So the one word that is being used to describe the psychedelic experience is ineffable. It's the ineffable experience that you experience it, but you can't really put words to really describe it. You can describe the map, but not the territory. And I think that EMDR has some similarity to that, some common traits that you can try to explain how EMDR works, but until you actually go through the treatment yourself, you're not really understanding, or you can't really conceptualize it. It's more logical when you're being trained, but if you get the treatment, you really understand on a deeper level how it works. So that's the set. The setting is the environment. So again, the environment is traditionally what's around you, right? Is it, are you in a concert, or are you going out? And, I had one client one time who took LSD, and they went to hang out with just the wrong crowd, just with people who are just really not nice to him. And it really gave him a bad trip, just by being with people who are really not nice. He didn't know them well. And so the setting has a lot to do with what the journey is going to look and feel like. So when you think about setting traditionally in a therapeutic environment, it's, what does your office look like? Is it cluttered? Does it smell like eggs that you had for lunch? Is your trash can full? By the way, it needs to be empty, because, if clients need some of the side effects of ketamine, for example, is that clients can throw up, they get nauseous. So it needs to be emptied and all that. But so the setting is the office environment. What kind of music are you using? What kind of speakers? I'm even going into the quality of the music. I think it's well worth investing in good care of speakers. And again, I'm talking with experience. I went and tried to do this kind of therapy myself with different therapists. And, sometimes they have an okay speaker, and it's different. It's a different experience when the quality of the music is really good. So that's the kind of like the broad definition of, or the general definition of setting. And what I think about is also the quality of the therapeutic relationship,
Mm.
right? Because if there's no safety and connection, we're sending our clients to face their, whatever you want to call it, that, their demons, their traumas, that, if you wanted to use the Jungian term, it's the shadow. And we're we're really, we need to be there for them, and they need to know on a deep level, even when they're, going into these unconscious material and their traumas and whatever's coming up, that we're there. And that's part of the setting.
I think that's a really important point, probably one of the most important things that you're saying, because in trauma, the reason why we hold trauma that it doesn't resolve when the experience happens is because we were alone with it, or we didn't receive
Right.
the attunement from whoever should have been able to
Whoever
meet
wasn't around,
us.
or
Right. They
was
weren't
around but
there, or they
wasn't
weren't able to
available.
respond the way that was needed. Right.
Yeah.
So we don't want to recreate that by having clients. And that's what I imagine when I picture people in infusion centers in a cold clinical room by themselves, going through this whole experience with nobody with them. It's not good.
Yeah.
So Rotem, I know we want to get to, I mean, we've kind of incorporated some of the questions that people have been asking, but we wanted to turn it over to just the Q&A.
Yeah, that's a good time. So for the people who watch this video on YouTube, if you want to watch the full version, if you're in training EMDR therapist, you want to watch the full version with the Q&A, we're also going to do some giveaways. You're welcome to join the EMDR learning community.
The EMDR learning community is free.
It's free. Yeah, it's free to join.
Okay,
Yeah.
so we're going to move to the Q&A now. Rotem Brayer, thank you so much for what you've shared with us about psychedelic-assisted EMDR so far, and now we'll move to the Q&A.
Sounds good. Thank you so much, Laura.